next goal of our objective would be how to take a history and examine the patient who comes to your clinic uh, for this complaint of hematuria. What are the points in history which should be sorted out, and should we investigate it, all those points, and then how to examine a patient. The third objective is what are the common reasons for hematuria, especially surgically, and then would be how to investigate hematuria. So, because we divide that into upper and lower urinary tract, and the last would be the few common risk factors for the urothelial malignancies or kind of tumors. So let's say I understand sometimes we have issue with the neck here. So sometimes the wash quality or the speed of the internet, because there are 6 people are giving lectures, so you might be hearing some crossword chatters. We'll continue our business. What is basically hematuria? How would you define it? Gross or visible is that you can see red blood, urine, and like this one, or in urinary pot, you see, or in our scenarios, some people uh, don't have that facility in their home, so they have this what we call it Indian WC. So their trousers, or what we call as underpants, or the shalwar is sometimes stained with a few drops. So we have evidence that they have one. Now, then is which is the gross hematuria, which has its significance, and it's the sight itself is very horrible to see somebody peeing of blood, and it's dreadful, depressing. So people will rush to the doctor and see what's the reason. Or macroscopic hematuria, which you don't see visibly, but if somebody has some kind of pain or other complaints, and you ask for the urine analysis, and if it contains the macroscopic examination contains reveals that there are more than 2 to 3 RBCs on a high power magnification on 2 occasions macroscopically, then it's called macroscopic hematuria. Or in female cases, if there are no menses or exercise, or somebody hasn't been to a urologist for urethral instrumentation like catheterization or TURP, which is transurethral resection of the prostate, enlarged prostate, or some dilatation for some stricture reasons. If there is no previous surgical instrumentation, or in a female case there are no recent menses, then the blood should not contain more than 1 or 2 RBCs on a high power magnification of the microscope. So basically, these are two straightforward definitions for hematuria. One is visible, one is non-visible. Okay, then history, when somebody is coming to us. So there are certain uh, points when patient is explaining or giving us a history, we should be focusing on those one, because that one will give us some clue of the uh, pathology or the disease process going on which is causing this one. So we should be giving more attention to the history. And what are those points? You can start writing on the chat box, and we'll see. But I'll try to give you a quick resume of those one. So if you start writing now, at least we can see that one. Okay, the next one, I'm sure you people have written at least two, three, four, five reasons, sorry, points in looking into the history, giving you clue. So I'm just going to disclose in the next slide what are those one. Now, now, if somebody has a fever, giving a history of back pain while passing a urine, urgency, frequency, it's most likely urinary tract infection. And if in the history he says renal colic or previous history of urinary stones, again, which is very obvious that it's because of the urinary stone disease, he's having hematuria. Somebody, when you inquire, he gives you a history of weight loss associated with the loin pain, then a sinister thing is sitting there, which is most likely renal cell carcinoma. Somebody with the weight loss and who smokes, I don't know, maybe 40 fags, or what do you call it, cigarettes a day for last 30, 40 years, or somebody who has been going to GPs or quacks or panwalas to get painkillers, and if he is using the non-steroidal anti-inflammatory, not the other group, paracetamol anti-inflammatory, which is diclofenac sodium, which comes in the name of diclowarin, whatnot. It's ever used for a long time, which means he or she takes every day for at least 5 to 6 months. Or somebody who has exposure to the industrial dyes, people working in rubber or naphthalene industries would have most likely, because as we know, it causes bladder carcinoma. People who work in a dye industry, people especially working in the rubber or leather industry, they used to tend to have one. If he gives a history of sore throat, edema, hypertension, then again a kidney disease would be the reason. Recent back pain, abdominal injury, or urethral catheterization, which is trauma, which could be the reason for his or her hematuria. Next in history, chest pain and dyspnea, we should be thinking about, if he is old age, then we would be thinking about myocardial infarction and atrial fibrillation. चैट बॉक्स यहाँ पे खुलेगा, मुझे नज़र आएगा वो अगर जवाब दे रहे हो तो, लेकिन उसको sorry, I'm just trying to see that one. ओके, कोई क्वेश्चन तो नहीं, लेकिन मैंने उनको कहा था कि मुझे उसके जवाब दे दें, उन्होंने नहीं दिए. चलो चलो. Then next is, as we discussed earlier, analgesic abuse, which causes papillary necrosis, and especially if we, oh, we are live now. I can see myself anyway. So because in our country, or in I don't know about India, but at least in our country, because of the poor control on the pharmacy system, you can get in the middle of the night at 2 o'clock, early in the morning, you get these non-steroidal anti-inflammatory at Panwalas, and people use it, and then they keep using it. And I had a patient in my private clinic for whom I prescribed specifically antibiotic and analgesia for 3 days, and I have written it because of the COVID, he was off for 6 months. He didn't turn up to me. He came back to me about a week ago, and he told me that he has been using that one regularly, antibiotic as well as non-steroidal anti-inflammatory painkiller for 6 months. So you can understand he has screwed himself. He didn't even bother to ring me and ask me, should I continue? I'm having this problem or not. So, and unfortunately, he's a literate person. He belongs to Balochistan, but that doesn't mean that you don't have, at least most of us, 80% of the population has access to the mobile phone. So that's how this our system is. So this papillary necrosis caused by even the non-steroidal anti-inflammatory abuse can cause the renal failure in long term. Hematuria with progressive renal failure as well, which is again papillary. Now that's history gave you a clue what could be the reasons. Now next you go for examination. So what you should look for? Can you answer? What you would be focusing on your examination? I'm still waiting for your answers on the first question. What would be the important points looking into the history? I can see in my chat box nothing coming up from the group. Can you just reply me? Can you hear me on the chat box, please? Hello. Okay. Now, would you tell me what would you be looking specifically at the when you are doing the examination? Just few things, then I'll forward the slide so I can see your answers. When somebody comes to you with the hematuria, okay, trauma, fine, edema, where? Okay. Now I'm going to give you a very quick run. What are the main points you will be looking while examining for the hematuria? It's the same general physical examination and systems review, which you have been doing on and on and on. It's never any kind of thing, but that's how you make yourself perfect on that one. So these are the few things you should be looking into it. Periorbital edema, any trauma, visible blood discharge. Okay. Now that's one. So examine the skin for rashes, ecchymosis, or petechiae, which is causing bleeding disorder. If somebody has this one, you would there will be evident petechiae or ecchymosis. Or if somebody has a trauma, there will be evidence. This is somebody's forearm. The next would be examine the cardiovascular for murmurs and atrial fibrillation, which gives you a clue if somebody is throwing a emboli, and most of the time it's old age that can cause, and he might be on the drugs for that reason. Then his blood. Then is you check for the costovertebral tenderness. If somebody is tender, it's pyelonephritis, means kidney infection, which again can cause the hematuria. And third would be you examine, palpate the abdomen, general physical examination again, and systems review. You palpate for abdominal masses, renal cell carcinoma, full bladder, and especially check the external meatus for blood. These are the points which you should be looking into while you are doing the examination for the uh, hematuria. Every patient, any patient. Now, causes. There are so many causes, surgical, medical. We won't be going into medical causes, though we should have a slight awareness of those one, because I'm a surgeon, so I'll be discussing more surgical things, looking into my uh, corner of wits. And can you just uh, write few causes what comes in your mind? I think it should be very straightforward. I'll hold this slide and wait for your few replies, please. Good. Okay. Ah, that's fine. Oh, okay. Okay, that's fine. Now see what we have. Now, trauma would be the first one. Second is the stone. Third one is infection of bacterial or parasitic leishmaniasis and all those bladder parasites. Inflammation, especially in old age females. It's called, what do you call it, inflammation of the bladder, cystitis. This gives them this. In male patient, benign prostate hypertrophy would be that one. Tumors, adenoma, 1%, transitional cell carcinoma, 90%, squamous cell carcinoma, 5 small cell carcinoma, lymphoma, secondary malignancies, melanoma, colon, breast, and lung disease. Drugs, all those drugs will be, especially, I'll give you a number of drugs that's for medical reason. That excuse me, would cause this one. And vascular malformation, AV malformation, this can cause bleeding, but that has to be investigated. So I think these are most of the surgical reasons for somebody coming up with the hematuria. We'll discuss them as a case wise and further down. Now, these are the medications which cause hematuria. Pyridium, europyrin, fenzoparidine, it's different names in different places, but it's analgesic. Sulfamethoxazole is antibiotic. Nitrofurantoin again is one. Rifampicin, which is more common in our use, it gives red color to the urine, not exact hematuria, but then one should look when asking for any medication and if somebody is on that. Now, ibuprofen is again non-steroidal anti-inflammatory, which is which comes in the name of brufen in our setup, and that again is the same culprit of non-steroidal anti-inflammatory. Dilantin, phenytoin, it's anti-epileptic, which can cause red color urine. Levodopa, methyl-dopa, again for hypertension. And quinine and chloroquine. Chloroquine is for anti-malarial, while quinine group again same, causing the red color urine. So these are a few medications which do cause this one. So just, I'm not a pharmacist or specialists, medical people to go into detail of these, but these are the common one. There will be, I'm sure, few more these which I could pick up easily, um, just for your knowledge. You can remember them if you want. See how frequently they are used, and can, if they are used, then you can be reassured that okay, this is most likely cause. But it should be investigated other than these one. If there is, or say somebody is taking is on those blood thinners, uh, people who have DVT are put on heparin and all those things. So these would, if with the warfarin, because after the injectable heparin, when you switch over to them to oral blood thinners, then that's a warfarin, and you titrate the dose according to your PTA, PTT, and INR. They should be therapeutic dose would be double the normal. So if it's somebody, it's INR normal one is 1, but when somebody is putting on warfarin, then INR should be between 2 and 3. And PTA PTT, if it is 35 is the normal 35 seconds, then it should be 75 or 70, 80 seconds would be your therapeutic range, just to know that your blood thinner is working properly. Now, these are three cases which I'll be discussing with you today. There is case one, there is 28-year-old male with gross hematuria. Then there is 49-year-old female with microscopic hematuria. And there is 67-year-old male with a gross hematuria and retention. So these three people, patients we will be discussing. Now, 28-year-old male came to your clinic. He has 2 episodes of gross hematuria, and which was self-limiting. Lower urinary tract symptoms for 6 months. He has a urinary hesitancy, decrease in the force of the stream. He's non-smoker. There's no pain. There's no trauma. So, what should we do with it? Okay, we will see. I'll answer. Somebody has asked me, sir, can you please specify which drugs cause red colored urine and which causes blood in the urine? I'll do that one once we finish this one. Now, does this patient need any evaluation? Answer is yes. He has a gross hematuria. It doesn't matter he's old, he's young, he's male, he's female, he's in between. We have to investigate. Now, history, he has a pain, and hematuria is usually from upper urinary tract, usually represents a stone or infection. Painless hematuria is usually more worsening, worrisome. Presence of clots usually indicates more significant hematuria. So, when he is giving a history, we should be remembering those points. Urine analysis, urine for CS, creatinine to outrule infection or renal failure. Creatinine and urea level will tell us whether kidney is functioning properly or not. Then urine cytology would tell us if there are certain nasty cells in it, which for which gives us suspicion of something wrong is that if they come up with atypical cells. We need upper tract, which means kidney ureter imaging, and lower urinary tract study, which is the gold standard, is cystoscopy. Ultrasound, very useful first line imaging, non-invasive. It can do upper urinary tract imaging very well, assess the masses, calculi, hydronephrosis, and It's easily available everywhere. Somebody asking, sir, can you go slide back? Okay, I'm trying to. Is this one? Or this one? Okay, so I'm going now. Ultrasound. Once we are done, then this next line would be CT, which would be technically giving us detailed examination if there is some suspicious lesion picked up on ultrasound or pathology picked up on the ultrasound. Now, this is ultrasound of the kidney, so I'll run it and you can see on the left side of kidney stones how they look on ultrasound. So I'll try to run it quicker if possible. It's the issue with our system that it loads. You can see this one. That's the pointer is there. So it's showing you a stone there. And if we see the live one, then it will be more easily. You can appreciate that one. That shadow there. And this one is showing you the probe on this picture, that it's directed towards the right kidney. And we have to, there is another stone. Basically probe is, though it is directing upwards towards the right rib cage, costal margin, but the probe is, the picture is this way. Now he's looking at left ureter, this long structure. And there might be okay, he freezes and counts. So that's another stone. Yes, left kidney cell system. It's kind of self-explanatory. I just wanted to run how the real picture looks like. That's a CTKUB. CTKUB is for kidney urinary bladder. Now this CT will again be running the same thing, but it's more kind of precise. You can see this hydronephrosis there, and this should be all jet black. There shouldn't be a gung like that. So that's one stone there in the kidney, and that's another stone on the left side. You can see this one. And this is holding it, and you can see this hold up. This is hydronephrosis. Now the parenchyma is there, kidney itself is there. There will be, if we go down further, we'll be able to see what is the reason. Can you see this one? That is the reason. That's a stone in the ureter. That's the ureter, you can see. So that's causing the hydronephrosis, roughly around 9.1 mm in one dimension, and it's 12 mm in the other dimension, so 1.2 centimeter. So that's how the kidney, the CT KUB, CT is more kind of informative, detailed examination, which tells us why this one is. Though the ultrasound did pick up the stones in previous slide, but this one exactly told us this is a different case. That's how it is. Now, lower tract infection radiographic studies do not outrule any urinary tract. Not 100%. If it is a huge one, it can be seen, but it's sometimes difficult. So the gold standard would be cystography, which will tell us the lower urinary tract, which means the urethra, whole length, and into the bladder. Other tests, urine cytology and markers. We don't have markers for at the moment established as a standard gold standard for kidney tumors or the ureteric tumors or bladder tumors. There are few markers, but they are not being generalized or recommended in general practice. The only one which is used for gold standard one is for the PSA, for the prostatic CA. Okay, so we'll see. Now, urological causes of hematuria in upper tract would be, as we discussed earlier on, renal cell carcinoma, renal calculi, obstruction hydronephrosis. Lower tract would be bladder cancer, benign prostatic hypertrophy, infection like cystitis or urethral stricture. Sometimes people have one, and when they want to pee, they can't because of the structure. They try to push it or force it, and it causes the mucosal lining of the bladder or the urethra bulbar or prostatic one to erode, and it starts bleeding. Now, in our first case, urine annals culture shows 1 to 5 WBC, 5 to 10 RBCs, no growth, negative for the sexual transmitted infections. So the renal ultrasound was normal. Now we need to do a cystoscope, okay, which showed this one. And if you probably, this is how it looks like. One, if you can see, it will be there. Now that's how it is done. Your scope should be able to pass through this one. If it doesn't, then this, you see, when he's trying to push, the mucosal lining is being disrupted. If you push it hard, then you can rupture it, you can have a bleeding, will be issues. This is what it is suggesting. So that's how the cystoscope would look like, and that's more than 1,000 ultrasounds better than this one that you can see with your own eyes. Okay, so that would be thanks, Dr. Jire. Now, the same patient, we are still, this is how we investigate. These were the results. So what should hematuria and lower urinary tract symptoms improved after cystoscopy and dilatation? Because when we see a structure, we dilate it. It's done. It's a specialist thing. Urology people would be more appropriate. In old days, good old general surgeon would do that. That they put few different sizes from smaller to larger one dilators. These are were gum dilators, or sometimes metal dilators. But now that thing has gone. Nowadays, either they can do structuroplasty or give a small cut and dilate it, or the other one is that you pass a small guide wire and there is a balloon, pneumatic balloon on it. You inflate that one with a millimeter of water pressure so that it dilates, and it dilates the structure. It has to be done a couple of times, but then it solves the rest of the issue. rather going for surgery. But if that one fails after a couple of times, then you do a surgery. And it's again has become a subspecialty in the urology. There are people who are just working on this one, and they have huge amount of experience under their belt for just doing these surgeries. And it's being done here in our SIUT also. Where we are in a sense blessed by Allah that because of the population explosion, we have so many numbers of the patient with the different diseases that we need so many hospitals everywhere. Institute like SIUT, every 200-300 miles we need those one. Anyway, we'll see. Symptoms reoccurred in 6 months: urinary retention, repeat cystoscopy with the urethrogram, 5 bulbar urethral stricture. You can see this one. That's the stricture. You see the urethra? It's retrograde urethrogram. So you push a dye through this one and it goes into the bladder. And then it should be normal size, should be this one, but this one is a structure portion. So he needs a surgery. Urethral stricture, fibrosis of the urethra and corpus spongiosum. Lower urinary tract symptoms, retention, UTI, hematuria. These are the complaints. Then etiology could be, excuse me, trauma, which is more common. People riding on bicycles, people riding on motorbikes, people having a fall on pointed objects, as we see every day, especially motorbike accidents. We have these one. So trauma is that. The other one is idiopathic. Nobody knows. Infection, yes, and just iterogenic. So these were the etiology for excuse me, urethral strictures. One of the causes of our today's topic is hematuria. These one can cause. Now, treatment, dilatation, as we discussed earlier on, then urethrotomy, forcibly opening the stricture segment, not usually curative, temporary relief, kind of thing. I know one patient who used to travel from Niamali to civil hospital. That is, I'm talking about 95, 98. He has been visiting him for a good 4 or 5 years. He would travel from there and he would come to his ward office to get dilated with the metallic dilators, and would go home, take a train the next take a train in the evening, and will go home and will come back after 3-4 months. So that basically was temporary relief. The urethral reconstruction, which is being done, there's a department now in SIEP, and there's one of our friend is heading it, short height fellow. He's very good at that, and the successful chances of those one are above 90%, which is very, very good. And sometimes they do a tissue transfer, which is buccal mucosa, because it's the same mucosa. So that's basically treatment for urethral stricture. That's, you don't have to exactly remember and tell it, but or in examination we don't expect you to give us this much, but because it is being discussed here, what are the causes, and especially if you were here in the ward, we would have been telling you the same thing. So yes. Now this is the second case, an incidental finding. He looks in agony, isn't he? Now, 49-year-old. Sorry, that was the different picture, and there is a written on as a female. Okay, Forget about the picture. We'll go through this one. Routine analysis dipstick, as we do in our casualty or OPDs, it shows +1 hemoglobin, macroscopic 5 RBCs, high power. Negative urine CNS, normal creatinine, no gross hematuria, non-smoker, no lower tract symptoms, and no pain. I think the word female is wrong. Again, if the only point here is other than is that his age is above 40, as we said 49, and he's male. So what should we, my only concern, I think I have given a clue why we should. Nowadays, yes, there is some question there that internal meateotomy is first line of treatment. Internal meateotomy is basically you put cystoscope and with the dividing either electric or a sharp ultrasound knife, you just try to release this stricture. Yes, but if you are working in a specialty in a general surgery, you won't have, or in different places you won't have that one. So yes, it's internal meateotomy would be one preferable, but then you will be seeing that in a specialty unit. So this one, because he's 40-year-old, as we have a general rule of thumb that anybody who is 40 going for surgery would have a chest X-ray. If he's smoker, again have a chest X-ray, and would have a ECG done because he's 40, just for the anesthetic point of view that they might have underlying cardiac disease, which is not giving symptoms, but these are the mandatory. Same thing is here. If somebody is 40-year-old with a hematuria and he need full investigation, yield of that is 11% for coming up with the pathology. Now, complete investigation not needed for the microscopic hematuria in a non-smoker, because as you have seen, I have come up with this term smoker and non-smoker a couple of times. There is a clue for that one, so we'll go when we go. The upper tract imaging is reasonable in all patients. Cystoscopy can be deferred in patient under the 40 without a receptor follow-up. Right? Then, when do people under 40 macroscopic hematuria require full cystoscopy? People with the risk factors for lower malignancy, smokers, as we said, occupational exposure to the dyes, radiation therapy to the pelvis, cyclophosphamide exposure, analgesic abuse. If they are below 40, then they need investigations with cystoscopy. Now, dipstick would be positive most of the time. Does that signifies, or is it necessary to investigate all dipstick positive patients? No. The reason is there are false positive, false negative. It could be positive in dehydration, myoglobinuria, somebody is having periods, and oxidizing agents like vitamin C can cause dipstick positivity because of the chemical reaction. So dipstick is helpful, but not to be chased around too much. Hematuria is urine dipstick accurate, sensitivity is 0.9, while its specificity 0.99, false positive 16%. So good for a screening. I don't think so. We do it regularly here. Now, when to suspect a nephrological or glomerular source? When RBC cast is there, proteinuria, dysmorphic, different shape of the red cells, and elevated creatinine. If these are present, there may be need to investigate. Now, how would we investigate? When we investigated the ultrasound, we found 4 centimeter renal mass on the ultrasound. No calculation. This is where it is. The mass is there. Sorry, I tried to upload the real ultrasound, but there was issue with the video of system, so couldn't get that one. Now, if somebody has this one, then normal. He had a normal cystoscope, a normal cytology. Ultrasound picked up this renal mass. Now, again, the CT is showing you the 4 centimeter left renal mass. It could be renal cell carcinoma, onychocytoma, angiomyolipoma, lymphoma. A solid renal mass is considered carcinoma unless proved otherwise. So it's basically, as it's time and again suggesting, and I'm sure everybody is now aware that the superiority of the CT on ultrasound. It's more detailed, gives you more information, and there are certain places where we are able to take biopsies, either throughput or final aspiration cytology, either ultrasound guided or the CT guided. Now, renal cell carcinoma is 3% of all adult malignancies, 90% of malignant renal tumor. These are the statistics which I'm sure you will be able to dig out from your Bayesian lab and just remember them. Reason being, sometimes the examiner might be asking you, or it can be a MCQ or VCQ and scenario-based papers, and will give you a different percentages, and you have to pick up the one and ratios. So just again, smokers have more von Hippel-Lindau syndrome. I don't know, but the last one, bad luck. Yes, it can happen with anyone without obvious reasons. Renal cell carcinoma present age 40 and 60. 60% are incidental discovered, as I said, bad luck. When I went for, say, suppose the patient went for ultrasound for different reasons, and they picked up this one. And Lord behold, I know one personal experience that one of patient went for abdominal discomfort, and they did ultrasound, but he has been having this one for the last 2 years. He thought it's just a food he's eating. And when they did ultrasound, they advised for CT, and it came up with the retroperitoneal leiomyosarcoma invading into superior mesenteric vessels, and it was inoperable. He was 58. He had chemo because he won't be able to have a surgery, curative surgery, or even palliative surgery. Different surgeons told him you will die on the table once, because superior mesenteric involvement means whole of the small bowel and the portion of the large bowel right side would be taken out. Definitely, life would have been miserable, and he would have died very soon rather than late. He survived, I think, 2.5 years. So that is bad luck. That he went for ultrasound or something else. He thought nothing would be there, and they picked up this one. So 60% are incidental finding hematuria. It can present as a hematuria. 15% of classic triad of flank pain, abdominal mass, and hematuria. Paraneoplastic syndrome, hypercalcemia, Cushing syndrome, etc. So, renal cell carcinoma diagnosis based on radiologic studies, incidental ultrasound, West imaging modalities, abdominal CT, generally do not biopsy. That's the message. Renal cell carcinoma treatment, localized disease, nephrectomy. That's the only cure we have. Radical versus partial, depending how big is it, how small it is bilateral or unilateral, or Then is the radiotherapy and chemotherapy. Both are ineffective. METs, palliative radiotherapy, bone lesions, tyrosine kinase inhibitors, these are just uh, handouts for helping him out for a few months. But surgery is curative if it is small lesion. If it is gone beyond repair, then just palliative chemoradiation. Now, this bugger is having what? He's having a bottle of bubbly in his left hand, and it's not Cabana or Castro's cigar, and he's having a laugh. He has hematuria. So, how would we go for him? 67-year-old male, gross hematuria for 2 weeks, passing clots per urethra for 2 days, unable to void for 8 hours, smoker for last 30 years. Urinary analysis shows hemoglobin 4 plus, more than 50% RBCs have our microscopy. Should we do anything? Should we ask anything, or should we go for investigation? Given his complaints. Now, we need to do a digital rectal examination, and the point of most focused thing would be I would go for this prostatic exam. Now is the prostate. Just focus on it. That's basically we should be doing it when we are examining it. We should concentrate on prostate. As we said, he needs an investigation because he's gross hematuria for last 30. What would be treatment? Should we put a Foley's? And if yes, then what type of Foley's? He needs a ultrasound, and he needs a cystoscopy in urine cytology, as we discussed earlier on the baseline investigations. Now, this is one which is for your practical. This was how to do a catheterization. So concentrate, because this will be one of your OSCE stations in your exam. So just concentrate. I'm going to show you. This is basically from New England Journal of Medicine videos. They are good quality, so I just copied them. This one, just have a look. That's a male. Catheterization. That's I'm sorry if there was, because I can hear it, but I've got a message that there was no audio on it. Don't worry, there is a next female catheterization. I'll try to run the commentary. I'm just trying to show you the basic urinary catheterization thingy. There is another video next to this one. I'll be running kind of commentary on it. Now, next one is the female catheterization. It's the same thing. I don't know why there was no audio. So this is video same from New England Medical Journal, Dr. Rafael Traeger. Now these are the indications. Now checking the balloon integrity, that's lubrication. So are you getting any audio there now? These are the indications for the catheterization. Okay, that's fine. It's it's just giving you the giving you the indications for different scenarios for female catheterization. So we'll be running those one. I've just muted the audio. Now the equipment we need for is the same. There is a sterile tray which comes with it, which contains the sterile wraps. One is fenestrated sterile gloves and forceps and few puts. This is the antiseptic gel, and this is lidocaine again, and this is what pre-filled sterile water. Then the connector with the catheter. These are the urine samples, and this is the bags, and these are the alco wipes. These are three different types of catheters. This is Foley's. That's latex material, or rubber. There's more one which is slip-on one. It's a bit tougher, and it can stay for 3 months if we wanted to have a longer time period. Permanent catheter. Foley's catheter is used in females. It's a double straight tube catheter with a balloon at the end. It's basically tested before putting into it. This is a 3-way catheter, triple lumen. It's for bladder irrigation after bladder surgery, or patient requiring irrigation continuous. And this is once off straight catheter to get a urine sample. The size of the catheter is basically is in French units, and it's in millimeters. And this latex is soft, so it is used. These are just different sizes and their uses. Basically, you should explain the patient the procedure, ask if he needs to know further, and he needs to be reassured that it's a straightforward thingy. Reassure him. These are the two different positions in which you can catheterize. No, it's basically examining the genitalia and trying to find out the urethral meatus, that one. It's a fibromuscular tube, roughly around 5 centimeter in length. Now, procedure again. Basically, it's a sterile kit, so these all are sterile. And it will contain the sterile. You have to wash your hand, and there will be a disposable drap which should be placed under the patient. Then, if before you put the sterile gloves, either you can wash your hand and then put the gloves and put the fenestrated drap on top of the patient. So the rest, other than the desired field, rest of the area is covered in a sterile glove. Now this is povidone iodine swabs, are basically antiseptic solution which needs to work. Now this sterile drap also contains back, that's left hand. Try to find out labia majora and minor are separated, and you can try to locate the urethral opening. Now this left hand has become dirty, but it shouldn't be moved at all. Then clean the whole area with the povidone iodine in a circular motion in a clockwise, and then they lubricate the catheter in your right hand and try to slowly advance the catheter into the if it is accidentally touch other non-sterile area, then throw the catheter out and get another one. Now in this technique they have shown that they have already connected the urine bag with the catheter. Normally we don't do it. We push the catheter in. Once we are sure or the catheter has gone all the way through the urethra into the bladder, then we inflate. Before inflation, we try to see if there is a urine coming out. And once we see the urine at the tip of the tube, then we try to push it another 1 to 2 centimeter further. And then the urine flows becomes larger, and then we connect the urine bag and inflate the balloon. So that's basically the self-explanatory. And we should fill the balloon as it is with the amount of sterile water which should be written on the channel of the catheter, which probably you can see there. This one will give you either 10 ml of solution like this one. It will give you the size of the catheter and amount of the balloon inflation. It should not be more than that. It should not be less than that. If it is partially inflated, say it says it's 10 ml and we inject 5 ml, then it can slip out. And this is how it is removed. We deflate the balloon first, and then we gently pull out the catheter. These are the complications. It's the same as trauma. If it is inflated in the urethra because of the incorrect insertion. These are the few complications which can cause the traumatic injuries. This is basically infection after the catheterization, which is common after 48 hours. And to avoid that one is not to catheterize, but in certain cases it's not possible, like frank hematuria. We have to catheterize. These are the difficulties when we encounter in catheterization. If you can't pass, then it could be in female that the pelvic organs are prolapsed. That's why you can't push it. If somebody is prolapsed, then in females, the digital rectal examination will push the prolapse end up and then put in, then it will be easy. This is another way of doing it, but then you are not supposed to. That's a technique for the especially female nurses when they have to do it, and especially it's a community health nurse. An obese patient, you would need an assistant to do the retraction and help you out. These are the few reasons for the no urine. the urine is not coming, then you massage the bladder and it probably come. It's the sterilization of the basically trap and all those things. So that's okay. Now clot retention, sorry, that was this catheterization. So then there's clot retention, bladder hemorrhage and large clots. Then we put a three-way, as we discussed earlier on types of catheter. That's a three-way. That's basically is for balloon channel. That's the middle one is for the urinary collection, where you connect the urinary bag, and this one is to connect with the irrigation solution. It's sometimes people use glycine or use the normal saline. The issue with the normal saline sometimes is that if you are irrigating it with a larger amount, say 3 to 4 liters, because the clots are there, and you have to run it continuously. If you do it slowly, then the clots will form and it will block the channel. So you have to run it faster, or just like opening a small tap of water. Then most likely you will be irrigating with 4 to 5 liters of normal saline. Now, with the issue with that one is that the normal saline will be, it has been reported that it's absorbed through the mucosa, and people will get into hypernatremia, hyperkalemia, or sometimes overhydration with that one. So one should be careful. So that's why they say glycine, because glycine is non-absorbable and it comes in a larger bag, 2 liter bag. You probably will need two bags for 24 hours, and it helps out to you. Normally what you do, you run it for 2 3 days until the urine is very clear, and you slow it down and there are no clots coming, or the rose water or pink color is no more there. Then you slowly remove it and then do the rest of the investigations, like cystoscope and all those things. But this is the first line of treatment. Old age coming, or young age, whoever is coming with the clots, then we have to put a three-way catheter and continuous bladder irrigation. Now that's a video of a cystoscope, technically speaking, just to show you how it looks when we are doing it. So then it's easy. That's a rigid cystoscope, and I'll try to fasten it so that the idea is to see how it should look normal, and I'll try to show you two ureteric orifices when we are doing a cystoscope, how they look like, and it will be at the base of your picture downwards. This is a rigid. There is another one called flexible, which is tube like this, but it's 3 mm smaller like this. He's showing you just small channels what they are used for. This one is irrigation, this one is light. So he's going in and explaining, trying to see on the left and the right side. Has turned the scope. Now it's 30-degree scope. Turn it upside down. He's looking at the rooftop of the bladder. Now that's one orifice, that's another orifice, ureteric orifice. That's how they look like. So that was the basic. So you can see whole lot through the cystoscopy investigation. You can do a therapeutic also through the same one. I think trying to close the screen. Now next one is this is the investigation, ultrasound, normal kidneys but possible bladder lesion there. You can see it, and urinary cytology shows atypical cells. That's the troublesome. Cystoscopy showed this one, papillary bladder tumor, and that was the cause for his passing frank blood with clots. The most common cause of gross hematuria over age of 40 years, male-female ratio is 3 to 1. Most common bladder tumor, 85%. Radiological investigation have false negative cystoscope is visual diagnosis. That's what we said in other earlier cases. Then is the resection of the tumor, which is called transurethral resection of the bladder tumor, TURBT. It is stages the cancer, treatment of the early stages cancer. It's resection. It is notorious to come back again and again. Cystoscopy surveillance every initially after removal it's 3 to 4 months, then you go to 6 months and a yearly one. Intravesical immunotherapy is also available. I think one of the famous politician used to have that one in England. Or radical cystectomy when the bladder has gone according to its classification, Gleason classification, gone beyond all layers. And it also have combined or chemoradiotherapy treatment options. The likelihood of tumors to develop within 2 to 5 years after the negative evolution is in 0 to 3%. So after 5 years, you just ask them to come every year, and then 3 years, and then 5 years. That's it. Cytology, urine analysis, and blood pictures checks 6 months, 12 months, 24 months, 36 months. Reevaluative gross hematuria, again positive or atypical urine cytology. New onset of irritative voiding symptoms without it. You have to reevaluate, go through a whole lot of the above investigations, ultrasound, CT, markers, if there are, if it is a prostate or the resection. This is the last slide, I hope. And this is an algorithm which we follow. This just go in the straight line. That's how we do this surgical thingy. That's also more on in the left side is more of the medical thing. So we don't go into there. Basically is sorry, go back again. This plasma creatinine, EGFR exclude, treat transit cause, include UTIs if above 45 years, urology assessment, cystoscopy and imaging. And if no cause is established or as cause is established and no cause, then primary care monitoring, annual assessment, while hematuria persist, BP and all those things. And then if there is a cause, then treat the cause. That would be it for today. I hope I have tried to avoid the lecturing thing, but this was supposed to be ward patient teaching, but because of this now new online thingy, that was the way we should go. At least we know how to treat those things. And the major chunk was to how to do a catheterization, male and female both. That was a video for that one. So that would be it for the day. Thank you very much for your patience and few questions. We'll see you again. Thanks. Bye.